My name is Silje Ljosland Bakke. Obviously, I'm Norwegian, but since I'm doing this with Heather, I'm doing it in English, so she can understand what I'm talking to, even though, well, I am from Bergen, so you might not be able to understand what I'm saying in Norwegian, but anyway, it'll be in English. I'm an information architect with National ICT, National IKT in Norway. And I'm also the coordinator or one of the coordinators for the National Archetype governance in Norway. And some of you, I know, attended the Vitalis conference in Göteborg earlier this year, and some of you, those of you who were there and saw my presentation then might have seen some of this before, but the main principles are still the same, but there has been some progress, so it might be interesting even for you. So, a little bit about the Norwegian hospital system. Norway has 4 regional health authorities, and altogether they have 24 hospital trusts. Each hospital trust runs 1 or more hospitals. All of these are using EHRs, so there are no hospitals who use only paper records in Norway. But opposed to the Swedish system, the Norwegian hospital system is completely separate from the primary care system. And this is causing a lot of problems with continuity of care and such, but I think you have a much smarter system here where they're more connected. All Norwegian hospitals use 1 of 2 EHR vendors. It's either DIPS or Siemens. Siemens is used in the central Norway regional authority here, this area, which comprises Trondheim, for instance. And DIPS is used everywhere else. The central health authority is actually in the process of changing from Siemens to something else. We don't know what yet, but at the moment they're using Siemens. Then there's National ICT, which is a strategic coordinating unit for health IT, which is owned by the 4 regional health authorities. It's been in existence as a coordination group, sort of loosely organized since 2002, but it was created as a proper health trust in 2014. The main responsibility of National ICT is strategic coordination in the specialist healthcare system. So again, you see the split between the specialist care and the primary care, also in ICT, unfortunately. In Norway, there's 1 hospital at the moment who's using openEHR in their actual clinical care. Oslo University Hospital started using DIPS Arena, which is the new product from DIPS, in October last year. And they're using some structured information using archetypes in the accident and emergency department, mainly for accident reporting. Several different Norwegian vendors are implementing structured EHRs based on openEHR. And National ICT is governing the national Norwegian archetypes. And the main goal of that governance is that the archetypes that are put to clinical use are of good quality through having been reviewed by many clinicians of wide spectrum of professions and specialties. And when I say clinicians, I mean anyone who does patient care in their everyday work. Not just doctors, not just nurses, physiotherapists, everyone. Sorry. Also facilitating semantic interoperability through enabling organizations and vendors to use identical data models is the other main goal. Once people get their hands on an archetype-based structured EHR, archetypes will just sprout like wildflowers, and data models will then start to diverge. This is theory, at least. And since data modeling is, well, I don't have any proof of this, so you're allowed to disbelieve me, but our experience is that clinical data modeling is hard. It takes a lot of time, and therefore it's expensive. And because of this, it makes sense to do this modeling just once. Share the results to avoid divergence, this set of shared models need to be governed very strictly. And then the templates can be governed a bit more loosely. And in 2012, National ICT realized that archetypes needed to be governed to avoid the mentioned sprouting of wildflowers. And this happened as a response to DIPS announcing their use of openEHR for their new system, DIPS Arena. They then asked the Western Norway Regional Health Authority to develop a governance scheme for archetypes. And this scheme was developed by the Bergen Hospital Trust on behalf of the Western Norway RHA during the summer of 2013. Then it was approved by National ICT in October the same year, and in early last year we bought the tools, we deployed the governance scheme, and the archetype.no site went online on February 7th, I think, last year. This is the organizational structure of what we're doing. At the top, this is, of course, organized by National ICT, and we have a national editorial committee. And the editorial committee is responsible for defining review requirements for archetypes and then approve reviews once the archetypes have gone through a clinical review. There are two coordinators, I'm one of them, and our job is to edit the archetypes, organize the reviews, and manage the archetype.no site. Each of the regional health authorities have a set of representatives in the editorial committee. Also, the Directorate of Health has one. We have, well, actually, we don't have, we want to have a national design committee. We haven't been able to get that running yet, but so at the moment the work of the design committee is done jointly with the coordinators and the editorial committee. But their job is to make sure the archetypes are technically good, that they can be implemented, and that they don't that they conform with other standards and formalism, such as we have some EHR standards in Norway from many years ago, and it would be wouldn't be an optimal situation if the archetypes completely contradicted what the old standard said. Then there's the regional resource groups, and we have some of them going now. The southeastern region and the northern region are getting those up and running. The main task of the resource groups is to recruit clinicians for reviews, so that we have actual clinicians who work with patients who can go and look at the archetype and see this is good, or no, this is bad, you need to change this, etc. And also, we've got the clinicians down at the bottom here. No, sorry. And we want the clinicians to take ownership of this themselves. If they want to have a structured form or a registry or whatever using archetypes, they should have someone to go to get support, to know how to make archetypes, to know how to make templates, because we can't expect the clinicians to know how to do this. So that's also the task of the regional resource groups, to be that help to the clinician when they want to do something with structured data. Then there's the vendors, and we wouldn't have been able to do this without vendors who actually create the software and bring this out to the clinicians again. If we were just doing this as a paper exercise, the clinicians wouldn't be interested. We need to be able to put this out into actual systems, and that's what we need the vendors for. They also suggest and contribute a few archetypes, but we shouldn't let the vendors run the archetype governance, but they can definitely suggest and contribute. And then there's clinicians. We do need the clinicians to participate in reviews. Without them participating, the archetypes would be horrible and completely unusable. And also, we want the clinicians to engage with their data and to start initiatives. And we have had quite a few initiatives like that. For instance, we had a workshop in Bergen last week where 2 orthopedic surgeons who wanted to have a fracture registry using archetypes. And they'd contacted us and wanted guidance on how to go about doing that. And part of the national governance scheme is the formal processes for development, review and approval of archetypes. And the development process is based on a model called a duocracy, Eurokrati in Swedish. Well, that was my horrible trial of speaking Swedish. It just means that it's similar to a meritocracy, but in a meritocracy, the people with a proven track record of doing something will decide what to do. In a duocracy, the people who actually spend the resources to do something make the decisions. And this means that the development isn't centrally prioritized. There's no committee deciding what to do and when. It's all decided by the actual requirements of whichever projects are going on at the moment. And this is very important to avoid losing momentum in the initiatives from the clinicians. If we're going out and saying, no, we want to do all of endocrinology first, let's forget about the orthopedics and other stuff. Let's do all of endocrinology, and then we can get onto these other things. Perhaps the endocrinologists are not interested in this. Then we're losing a lot of work, and we're not actually supporting the people who want to do this. So that's why we're doing it as a duocracy. I'm going to try to pronounce it in Swedish again. We're doing a lot of online collaboration through 2 different tools. One is the Clinical Knowledge Manager that Heather showed briefly. We're going to show that more in a while. And the other one is a wiki, which we use to document the processes. And both of these tools are very critical for this transparent online collaboration. The National Editorial Committee defined the review requirements of each archetype, which basically means that which professions, which specialties should and must take part in the review of every single archetype. Review rounds usually last 1 week, and after the week the requested changes are made, a new round is started, and then it goes on and on like that until the clinicians agree, hopefully. And they usually do. But you might have from 1 to, I think we've had 6 at the most, review rounds for each archetype. At the moment, for some of the archetypes, we're doing this in parallel with the international reviewing. So the international review rounds are usually 2 weeks. And we do the 1 week. Within the space of the 2 weeks they do internationally, we feedback from our clinicians to the international space. Then the changes are done internationally, and we take the changes back, which means that we end up with identical archetypes to what the international space does, which is it's good because we have even more interoperability, and it's good because we save more work. Unpublished archetypes that haven't gone through the review process, haven't been published, should not be used. This is the theory. Thing is, they're unstable. They can change massively overnight. And that would be a huge problem if a vendor implemented an archetype and then we changed it completely. As I said, this is the theory. In practice, we're seeing that they are used, but we're trying to discourage it. Our main approach in this is to support all the archetype needed by the vendors and the healthcare providers, as I mentioned earlier. We also initiate reviews of certain very basic, ultra-reusable archetypes, such as the problem diagnosis, the symptoms and the procedures and other things that will be used everywhere. And we also spend quite a lot of our time telling people about what we do, as presentations like now, courses, workshops, etc. During last year, we only managed to publish 6 archetypes. The thing is, 5 of them were in December, which meant that we had a huge increase in our speed of review during the year. And the thing is, clinician participation is very important to be able to do this quickly. And we took a lot of time to build up our base of clinicians. I think we hit about a limit of about 150 clinicians registered in this tool in October, November, and that's when speed started to pick up. As of today, there are 27 published archetypes, and this doesn't sound like a lot. But some archetypes are more important than others, as I mentioned there. In other words, they're more reusable. And once we have, say, 30 to 50 of these very reusable archetypes approved, we can probably represent at least 90% of primary care in a structured way. Then we, of course, have to do all the specialist stuff for the specialist healthcare system. But at least we don't have to spend more time doing the things that will be used everywhere. The Clinical Knowledge Manager is an open tool where anyone can register for a user account and participate in the reviews. And as you can see, we have had an almost linear increase of registered participants, up to over 300 as of now. They can also record their profession and health domain, which is the basic for our selection of who gets invited to each review. You can also request to be invited to reviews for a certain archetype by adopting the archetype, and we'll show you that later. But as you can see, only about half the users have recorded their profession, which means that even if they wanted to participate, we won't invite them to reviews because we don't know who they are, what they do. We want to be a little more specific in who we invite, so we don't invite people who have no interest whatsoever in the archetypes that we're doing. All in all, only 56% of the users are actually eligible to be invited to a review, unless they actively adopt the archetypes themselves. This graph shows the proportion of users who are mainly clinical and actually work with patients. As you can see, it's more than 50%, which is very happy about that. The users who have either a purely technical background or a combined clinical or technical background and don't see patients regularly in the other, this bit here, and they're broken down to different professions and groups there. As I said, we're very happy that we have so many active clinicians participating. This kind of thing is a thing that often attracts the ones who mainly work in IT. So we're quite happy about this. We've identified some success factors to what we're doing. Obviously, clinician participation is crucial, since the clinicians are the ones who both define and approve the data models. Next, without the good tools we wouldn't have been able to get the clinicians involved. Doctors and nurses don't want to read through long PDFs with UML diagrams and then write their response in a Word document. The coordination of this governance scheme takes a lot of time and couldn't have been done without dedicated resources. And this sort of thing is new to almost everyone. And without the means to do training and consulting with international experts, making good models without making too many mistakes would have been much harder. Finally, since there's a sizable international community also making and sharing archetypes, we haven't had to make too many of them ourselves. Actually, almost all of the archetypes that we've published in the Norwegian Clinical Knowledge Manager have been translated from the international archetypes, which means that we've saved quite a lot of work just by using what's already there instead of trying to reinvent the wheel ourselves. Also, and one thing that I didn't mention at the Vitalis conference was the vendor participation. As I mentioned a few minutes ago, without the vendors actually taking and using the archetypes and the clinicians seeing what this can do in their everyday work, or at least having some kind of idea that they will be able to see this in a production environment in their everyday work within a short period of time, they wouldn't be interested in doing this. So this is very important. We have some problems that we anticipated, but we haven't been able to mitigate in any way. That's standardization takes a lot longer than not standardizing, and this is true for everything. The thing is, project planning should take that into account when they're doing their planning, but they aren't. So that leads to the fact that some unpublished archetypes are actually being deployed as we speak. There's one system going online in Oslo on November 15th that's using a lot of unpublished archetypes. And that's because we haven't been able to follow the pace set by the project managers, partly because we're probably a little bit under-resourced, and partly also because they haven't been planning for this kind of development. They haven't been planning for the old kind, where they just define their data elements as they go in an ad hoc way. Also, we're missing quite a few specialties. Like, we don't have any neurosurgeons, which means that we can't review the Glasgow Coma Scale archetype. So that we're stuck there until we get a neurosurgeon on board. Really slows down the review process in some areas. And of course, we're only 2 coordinators, which is a little bit too few when we're both at work. And when one of us is in Trondheim for his master's course and I'm here speaking to you, no reviews get done. So we need a little more redundancy. So we should have been at least 3 people. Also, then there's a few things that should have been done better that we didn't anticipate, and that's the time and the difficulty of translation. Most clinicians can speak English to a certain degree, but very few of them are trained to do their work in English. And that's a huge difference. If you want to translate archetypes from English to Norwegian, you actually need to know what the clinical language in English, and that's very different from conversational English. I mentioned this in the last one. I'm repeating it here because it's so important. The projects they're not used to having their information models reviewed and improved before they can be deployed. And from our point of view, this would work much better if the models were developed early in the project, perhaps even in a separate project before the implementation begins. And of course, as Anna mentioned, the regional resource groups are hard to get going because the regions haven't completely seen why we need these groups. They're sort of getting there now that they're starting the implementation projects, and more and more clinicians are asking for archetypes. But they haven't until now, and that's been a problem, especially for us having to recruit the clinicians ourselves, which leads to us not having any neurosurgeons to review the Glasgow Coma Scale archetype. So this can also be a huge bottleneck. And I think I should let Heather start with the international space now.